This conference will now be recorded.
Welcome in, everybody. Today's lecture, we're going to be talking about burns, which is going to be correlated into chapter 29 within your textbooks. So let's dive in. First, looking at our learning readiness, these are the textbooks, textbook chapter and pages that you should be reading prior to this lecture. This is going to be our objective. So we're going to review the anatomy of the skin, pathophysiology of burns, and then also classification of burns, and then dive deeper into patient assessment and specific treatments of said burns. So let's take a look at our case study. We have EMTs White and Thornhill. They responded to a 62-year-old woman lit a cigarette in her car while receiving oxygen by nasal cannula. The patient is awake and sitting up with burns of her face, neck, hands, and forearms. The patient's hair is singed and she is coughing. So the priorities in managing this patient. So pathophysiology of those burns and the specific classification. She introduced oxygen and that flammable content of that cigarette lighter, and as a result, we had a chemical reaction of said burn. So the biggest priority in dealing with this patient is going to be airway and breathing, because this patient most likely has COPD, so they need oxygen in order to survive, and they are on continuous oxygen. And the fact that we introduce that burn to a respiratory system, excuse me. So that burn is introduced to the respiratory system, and as a result, we're going to see a heavy amount of swelling, inflammation, and then also damage to the upper bronchioles from that small explosion. Factors that will help Ariana and Bell determine the severity of the patient's burns. So there's going to be a couple of different components that we can utilize in order to classify what's substantial and what's minor burns. There is a couple of different rubrics that we can use: the rule of palms, the 9% rule, and then also specifically where those burns are located. So anytime that there's a burn that's affecting the respiratory system, this is going to be a high severity burn classified with it. Introduction. So burns affecting multiple body systems, in addition to affecting the skin. So this is going to be a substantial burn. Body temperature regulation, very significant concern in burn patients, because we got to be thinking of what the skin specifically does. So the skin, it regulates our water balance, it regulates our body temperature, and then it also is the first line in defense for any type of pathogen trying to enter into our body system. So when we have a substantial burn that's affecting a large percentage of the patient's skin, we are losing a lot associated. First off, we're losing the body temperature regulation. So a lot of body heat is given off, and that's why we see a lot of patients who experience a large burn actually go into a hypothermic state. So think of a time where you got severely sunburned and you can actually feel the heat coming off of that sunburn. That's actually your body heat being dissipated through your skin, because that specific portion of your skin is actually damaged. So it's not able to actually keep that body heat within your body system. And then last bullet point, EMTs have an understanding of types of burns and how they affect patients. So many different types of burns. We have thermal burns, we have chemical burns, we have radiation burns, which we're going to dive into in more detail once we get to that specific section. So review of the anatomy of the skin. We have 3 layers of skin. We have the epidermis, which is mostly composed of dead skin cells, and then hair. We have the dermis, which is more affected with different types of tissue, and then also our hair follicles. And then we also have the subcutaneous layer, which is going to be our fat and then our muscle tissue as well. The skin is the largest organ of the body. And so with that, when we're looking at the different layers of the skin, we can start to see the different classifications of those burns. So when we have a 1st degree burn, that's going to affect the epidermis. We have a 2nd degree burn that's going to affect the epidermis and the dermis. 3rd degree burn is going to affect the epidermis, the dermis, and the subcutaneous layer. And then they're starting to talk about 4th degree burns as well, which is going to affect the epidermis, the dermis, the subcutaneous layer, and it actually impedes and causes damage to the bones within that specific portion of that burn. So, functions of the skin, we already talked about this. It's going to provide protection. It's going to provide thermal regulation. It's going to provide water balance. And then it also aids in the production of vitamin D. We get vitamin D from the sun, and it's kind of a photosynthesis correlated as far as plants to humans obtaining those vitamins from that specific sun. Pathophysiology of our burns. So most burn patients die in the pre-hospital setting from an occluded airway, toxic inhalation, or other significant trauma. And again, that burn with our case study, it's going to affect that respiratory system, and that respiratory system swells significantly. And as a result of that, that patient can go into a hypoxic state, which leads them into a cardiac arrest scenario. Very important as far as treatments go that we try and maintain a patent airway. So if we have a patient who has a substantial respiratory burn like that, what we're going to do is we're going to start to think about more advanced and aggressive airway treatments for these patients. So for this patient, if they are starting to deteriorate, their respiratory system is swelling, I might think about dropping a King airway or immediately call advanced life support in order for us to secure that advanced airway so they're getting the proper oxygenation. Other things is control any life-threatening bleeding. Burns, we don't see a lot of active bleeding associated with it. We could see some internal bleeding, but as far as external bleeding, not a lot of bleeding is going to be associated with it. Circulatory system, with a substantial burn, especially when we're looking at second and third degree burns, what it's going to cause is a significant shift in fluid loss. So our patients oftentimes are going to be in a hypotensive state with that decrease in blood pressure. Can also see significant edema, and that's going to cause even more loss within that fluid regulation of that body system. Within the respiratory system, we talked about the thermal burn, which is our case study, but there's also a lot of different other toxic inhalation injuries that are going to cause burns, such as cyanide, carbon monoxide, sulfur dioxide, and hydrogen chloride. So when we're looking at scene safety considerations, if we have multiple patients who are displaying the same signs and symptoms, we have to be wary of that and then call in that hazmat team in order to properly decontaminate these patients before we start providing treatment for them, or else we're going to be introduced to these hazardous materials as well. So when we have a patient who experiences signs and symptoms from one of these poisonings from toxic gas, which is associated with their burns, heavy airway treatment, heavy oxygenation and breathing treatment. So we're going to be assisting ventilations. And this is a time that we have to properly don our PPE too, so that we are not contaminating ourselves as well. Other things, our renal system, so our kidneys, what they do is they flush out the toxins within our system. And so if they get severely damaged, that patient can become septic because of that increase of toxins within the body system. So we could see those kidneys fail, and then as a result, that patient's going to get severely ill from a massive infection throughout the system. And remember what I said, when that skin is compromised, now we can actually introduce a lot of pathogens into the body because that's our first line of defense. So burns are a substantial emergency because of all these different aspects within pathophysiology, where we are losing our body temperature. So now we have a patient who's hypothermic. We're losing our fluid shift within our body. So now we have a patient who's hypovolemic. And now we are introducing a lot of bacteria infection into the body. So now we have a patient who's septic. And that's why when we look at the morbidity and the mortality rates of significant burns, is we are introduced to an uphill battle of trying to treat multiple injuries and multiple things that are going on that pathophysiology of that. And then as far as musculoskeletal and gastrointestinal systems, these aren't going to be our priorities when we're treating our patient. However, they do play a significant role because we want to try and ensure the best possible patient care. So significant injury to the hands, the extremities, they could actually lose the function of those extremities. And that's why it's important to cool those burns, treat those burns, and get that individual to a specific burn treatment center. Classification of our burns. So we have first degree, second degree, third degree, and then fourth degree. So first degree also classified as superficial, which we are only introduced to the epidermis. Second degree burns, those are going to be our partial thickness, which is going to be our epidermis and our dermis. Third degree burns, all 3 layers of skin, also classified as full thickness. And then when we have fourth degree burns, those are going to be classified as actually a result of injury to the burns or the musculoskeletal system.
This conference will now be recorded.
Sorry about that, everybody. Need another cup of coffee. So moving on into those classifications of those burns, what we're going to see specifically when we are looking at first degree, second degree, third degree, and fourth degree burns is first degree, again, only affecting the epidermis, so it's going to be redness of the skin. Significant sunburns is going to be classified like that. When we see blistering, that is going to be a result of that burn affecting the dermis layer. And then when we start to see tough, leathery, dead, soft tissue, blackness, discoloration, those are going to be signs of our third degree burns. So as we can see, first degree burns, this individual on the left, it's got that burn to the right shoulder, back, and then a little bit onto his chest. We got red skin, it's going to be pain. There's going to be some tenderness, but we're not going to see any blisters because it's only affecting the epidermis. Now, if it was more substantial and it affected the epidermis and the dermis, that's where we're going to see intense pain and then blistering. With third degree burns, again, we see that dark black or that brown or that charring, and oftentimes because of all the layers of the skin being affected, all of the nerve tissue is actually damaged and burned off at this point. So this individual actually does not feel pain at the site of that third degree burn. However, everything around that third degree burn most often is going to be second degree burns and first degree burns. And so they're going to see a substantial amount of pain associated around the burn. So as far as some EMT skills, so this is going to be identification and treatment. We have a first degree or superficial burn. So what we're going to do is go ahead and cool that burn with sterile water. Err on the side of caution as far as introducing sterile water or cool water directly on that burn site. But with first degree burns, you're more than welcome to do so because that's going to help with the pain, and then also it's going to help with the tenderness of that. Same treatments. We have a second degree burn. Let's go ahead and cool that burn. And then the same thing, third degree burns. We're going to go ahead and start to be a little bit more aggressive with our treatment. This individual has got some signs of those third degree burns, but it's affecting the respiratory system. So we want to make sure that we're aggressive on the oxygenation therapy of that patient. So when we have full thickness burns, so this is going to be our third degree and our fourth degree burns. Again, aggressive airway treatment. And then with cooling those burns, we're going to have to really be careful because when we start to cool those burns, then that patient is going to go into a hypothermic state very, very quickly. What we're concerned about here too is that fluid loss within that patient. So always, always, always with a significant burn, be considering advanced life support for your additional resources, because we need to start introducing fluids into this patient as soon as possible. As far as transport goes, remember that we really only have one substantial burn center in the area, and that's going to be Miller-Dwan, which is affiliated with Essentia Health. So when your patients want to go to the emergency room, significant burn injury, always err that they should go to Essentia. So you're going to go to Essentia into the ER, and or hopefully you can directly take that patient to Miller-Dwan. So when we're determining the severity of the burns, there's a couple other things that we're going to classify. So the depth of the burn, differentiating first degree, second degree, third degree, the location of that burn, the patient's age, any pre-existing medical conditions, and then the percentage associated with how big that burn is. So when we have a burn injury location in the face, that's a substantial burn because of the risk of the inhalation injury. When we have a burn to the hands and the feet, there is a chance of that loss of joint function. And then if we have a circumferential burn, that's going to encircle the entire portion of that patient's body area. So we got to be thinking of, that's a substantial injury because there's a lot of body surface associated with it. And then also how much is actually going to compromise below that burn. When we're looking at age, children under the age of 2 and adults over 50 have a much less tolerance for that burn injury. And it's because of lifespan development. So children under the age of 2, their skin is very new to them. We have not introduced it to trauma, different chemicals, harm, in which that skin actually becomes more and more resilient over time. And then anybody over the age of 50, that skin begins to deteriorate again. Children, much greater potential for that fluid loss because they don't have a lot of fluid in their system already. And then we also got to be considering any type of child abuse when we do see a child with burn injuries. So when we're looking at critical burns, this is going to be correlated to any type of full thickness burn involving the hands, feet, face, eyes, ears, and or genitalia. Any burns associated with the respiratory system, when we're looking at percentage, any burns that are more than 10% of the body surface area, any partial thickness burns covering more than 25% of the body surface area. When we have our age demographics, anybody less than 10 and or greater than 50 if it's a partial thickness burn over 20%. Chemical burns, high voltage electrical burns, because this could cause cardiac dysrhythmias. Burns complicated with fractures or major trauma, because that's also going to hinder the ability of hemoglobin production and then bone marrow production. Moderate burns, young children, elderly patients, and then circumferential burns to the chest, the legs, and or the arms. So based on the American Burn Association, these are the severity of the burns, and these are the specific classifications correlated to that severity of the burn. Now you can see this in your textbook, so I'm not going to go one by one, but be thinking of seeing these burns, how you're going to treat those burns, and then also which destination or hospital that you're actually going to take that patient to. So when we see a cinching of the hair around the face and the eyes, be mindful of what that's actually going to do to the respiratory system. So when we're looking at burn size, we talked a lot about the percentage. So there's a rule of 9s and then a rule of 1s, or the rule of palms. So the rule of 9s, quick assessment as far as what the percentage is. And we're going to see a picture here within the next couple of slides. But basically, when we're looking at major body surfaces, they're correlating it to 9, so 9%. When we're looking at the rule of palms, your palm of your hand, or excuse me, the palm of the patient's hand on the body surface area is 1%. So if you can cover up that burn with the patient's palm, and it takes 4 palms, that's 4%. Other types of burns: thermal burns, inhalation burns, chemical burns, electrical burns, and radiation burns. All of them have different effects on the pathophysiology of the system, and each one we're going to do a little bit different treatment plan. Cause of the burns: flame burns, so those are going to be our thermal burns. Contact burns, so this could be chemical and or thermal. Scalding, that's going to be most likely from high temperature water. Steam burns, self-explanatory. Then we have gas, electrical, and flash burns, which are going to be more chemical-based burns. Our assessment, first off, always ensures scene safety. So again, multiple patients with the same signs and symptoms, be wary of hazardous materials. If you can mitigate that scene to make it safe, go ahead and do so within your scope of practice and within your specific skill set and your operational guidelines. First, primary assessment. So this is going to be identification of immediate life threats. So if that patient is still in contact with that burn, that's going to be considered an immediate life threat. So we are going to go ahead and mitigate that prior to any other type of assessment. So remove them from that source of burning, and then within 10 minutes of that burn, cool that burn with water or normal saline. Jewelry, rings, bracelets, necklaces, make sure that you remove those because we're going to see substantial swelling from that burn. We're going to assess airway, breathing, oxygenation, and circulation, and then fix any issue associated with that as soon as we identify it. So we assess the airway. If the airway is blocked, insert an airway adjunct, readjust the airway. Assess the breathing, patient's not breathing properly, assist ventilations with high flow oxygen. That way we're fixing the oxygenation. Circulation, treat for shock, keep that patient warm, and then go through your cardiac arrest algorithm if that patient is in cardiac arrest. Within our secondary assessment, reassess the mechanism of injury and chief complaint. So mechanism of injury is going to be from the burn. Chief complaint is going to be whatever that patient is complaining of. So most often they're going to be complaining of significant pain. They're going to be complaining of difficulty breathing if it's associated with the respiratory system. Then dive into any other type of secondary injuries and then treat those if you have time. Our secondary injuries, which are considered non-life threatening, if you have a substantial burn or a critical burn and you're dealing with airway, you're dealing with doing chest compressions, don't even worry about those secondary injuries. Continue to remove all the clothing, determine accurate body surface assessment or that burn surface assessment, obtain those vitals, and then obtain those history. Our signs and symptoms, so look for any type of inhalation injuries and then start to do your rule of nines and or your rule of palms in order to determine that specific area. So here's our question. Click on the burn depth that is categorized by dry, tough, leathery skin and an absence of pain in the immediate area. So we know that first degree burns and second degree burns are associated with high levels of pain. So immediately we can eliminate superficial and superficial partial thickness and even deep partial thickness because those are both correlated to first degree and second degree burns. Absence of pain immediately, that's going to be full thickness burns. So back to our case study, Bill and Ariana are concerned with the mechanism of the burn since the patient was in an enclosed space and the gas that ignited was in contact with the respiratory system. The patient is coughing, has a history of medical problems requiring supplemental oxygen. In addition, they are concerned by the location of the burns of their face. They estimate the burns to be both superficial and partial thickness, and they involve about 15% of the total body surface area. Would these burns be classified as minor, moderate, or severe? Let's go ahead and support our answer. They are going to be classified as severe burns because they're associated with the respiratory system. And then also we have greater than 10% associated to the face. So that's immediately going to be a critical or a severe burn. What criteria is present that would support transporting the patient to a burn center? And it's because we have second-degree burns associated with the face and the respiratory system. So that's an automatic classification that that patient is going to go to a burn center. So other emergency medical care that we're going to provide. Never enter an unsafe environment. So that's step one of our patient assessment. Determine whether that scene is safe. Do not remove adherent materials from the burn. So if something's actually stuck to that burn, don't remove it. Brush away any dry powders before flushing with water, because we don't know if those dry powders, those chemicals, will actually interact with water. And then remove any smoldering clothing, remove that burn source. So stop the burning process. So go ahead and remove the clothing around that and immediately start cooling that patient's burn. So this is a small area. I'm willing to bet that we could probably cover up that burn with the patient's hand with two of their hands. So that's going to be 2%. It is affecting an extremity, so that's cause of concern, and we can see that we're starting to see that black charring, so that could actually be a full thickness burn. So we're going ahead and start that cooling process. Remove any of that smoldering clothing, and then I'm going to remove their shoe and their sock as well in the event that we have swelling within that extremity. So furthering our emergency medical care, maintain that proper airway, breathing, circulation, administer oxygen in the event of a toxic inhalation, or if those SATs are below 94%. Then what we're going to do is we're going to cover that burned area with a dry, sterile dressing, a burn sheet, or approved commercial dressing. So moist dressings, err on the side of caution on this because this can lead to hypothermia. So the best thing is to cover with a dry, sterile, non-stick dressing. So some systems allow for dressing for moist dressings less than 10% of that BSA. So I'll always follow your protocol associated with this. Anything over 10%, do not put moist dressings on there because that's going to leave that patient going into hypothermic shock. So there we're covering non-stick, sterile dressing. Keep the patient warm. So this is going to institute our shock classification and then transport to the appropriate facility. Again, this is reiterating what we already learned as far as major burns and our critical burns. So reflect on that table. Other types of emergency care, when we have an individual who's got burns to their hand, make sure that you separate the digits with dry, sterile dressing so that skin deterioration does not stick to each other. Very important so that we can save that extremity, hopefully. Burns of the eyes, don't attempt to open burned eyelids if they are cinched shut. Apply sterile dressing to both eyes and then flush any type of chemical burns. Make sure that you're doing this so that if one eye is affected and the other one is not affected, that runoff is not actually getting into the non-affected area. There we can see a very good example of separating those digits so that they're not interacting with each other. And then burns to the eyes, covering both eyes. Any type of eye injury that we have, if we have one eye affected and one eye not affected and we have to cover up that affected eye, we always cover up the non-affected eye because our eyes always work together. Regardless if one eye is closed, our eyes will still be tracking even if one eye is covered. So it could cause more damage if we're not covering up both eyes. So our reassessment, any type of unstable patients, we're always reassessing after 5 minutes. Any stable patient, technically every 15 minutes, and always continuous evaluation of that patient's airway and breathing. For chemical burn, make sure protect yourself, get that chemical off, and then for most chemicals, we're going to go ahead and flush with copious amounts of water. Most often, we're going to be responding to an emergency within a plant that these individuals know specifically what chemical that they're working with and what chemical interacts with water. So hopefully that patient is alert, and or there's other crew members on that scene that say you cannot actually flush this chemical with water. They're most likely going to actually have specific chemicals within their burn kits at that specific facility that's going to help you with that treatment. So here we have a partial thickness burn around the patient's ear. So that's a substantial injury because that could go ahead and intervene with that patient's ability to hear. We have a chemical burn. So this is going to be classified as a 2nd degree burn because we have that blistering. So special considerations with those chemical burns. Dry lime, that actually interacts with water, and so does sulfuric acid, carbolic acid, and hydrofluoric acid. And again, all of facilities that carry these chemicals, they need to have the specific antidote for those burns. So with lime powder, a small amount of lime powder that's still on, you can go ahead and use flushing techniques with copious amounts of water after you go ahead and remove the bulk of that powder. Example of flushing that chemical from the burned eye, and you can see that that patient is tilted so that that runoff is not getting into the unaffected eye. For electrical burns, this poses a specific issue for us because it can cause that patient to go into cardiac arrest because that significant electrical energy that's being introduced into the patient's body could cause a cardiac dysrhythmia. So make sure, scene safety, remove them, and then look for those injuries. So oftentimes you're going to have an entrance wound and an exit wound, or you could just see one wound where it's grounded. So try and identify where that patient's grounded and then go ahead and cover that up. Most often that injury is going to go ahead and be cauterized, so you're not going to see any bleeding or anything like that. But be ready to go ahead and start delivering CPR and utilizing that AED to try and eliminate that cardiac dysrhythmia that that patient went into. There we can see the entrance wound and the exit wound. So on the left, that's the entrance wound. And then on the right, we can see where it was cauterized. So that's going to be the exit wound. Another type of contact burn, so this is going to be a high voltage line. So we're going to go ahead and cool that burn, heavy amounts of water, and then cover it up with a dry, sterile, non-stick dressing. So diving deeper into our scene size up, be on the lookout for any of those significant injuries and or significant scene findings. Assessment findings that are going to make us very concerned when we're doing our general impression, when we're walking up to our patient. If we hear stridor, then we know that that respiratory system was affected and those bronchioles in the upper airway are already being constricted and inflamed, and that's why we hear that abnormal sound. Other things, burns to the neck and the face, if we have obvious burns to a lot of the clothing, if we have singed hair around the face area, and then also if that individual is starting to spit up black sputum, we know that that burn got heavy and deep into the lung areas. Assessment findings with breathing, oftentimes these individuals are going to be breathing fast. upon that preliminary burn. And if that burn is significant and it takes us a while to get there, then everything is going to start to deteriorate and decompress. So the respiratory system eventually is going to slow down once that patient starts to go into decompensated shock. Our skin, oftentimes it's going to be normal in unburned areas, but maybe cool and clammy depending on how much fluid loss was actually associated with that patient. When we're conducting our physical exam, do a really good detailed exam with a specific area of that burn site. But then when you're doing your head to toe exam, be looking for those secondary injuries and those secondary sites of where that burn could have possibly gone. So when we're doing our head to toe, first check our head and our face, looking for any injuries to the respiratory system. When we get down on the chest, look for burns, wheezing. This is when we're going to auscultate our lung sounds, and then be looking for any type of blunt or penetrating injuries from a fall or from an explosion. Abdomen, same thing. Extremities, same thing. We're looking for significant injuries, significant burns, and then any other musculoskeletal trauma that might have occurred. When we're looking at our vital signs, they could be normal, they could be increased, and then eventually they're going to decrease depending on how significant that injury is. So what we're looking at is different types of shock. Compensated shock, that first initial injury, that patient is going to be able to compensate. So heart rate, respiratory rate, blood pressure, that's all going to be increased. When that patient starts to lose a significant amount of fluid, or they go into hypothermic shock or other types of shock, once they get to that decompensated phase, their heart rate is going to begin to decrease, their blood pressure is going to begin to decrease, respiratory system is going to decrease, and then eventually SATs are going to decrease and that patient may go into cardiac arrest, which is going to be marked by irreversible shock. So our history findings when we're going through our OPQRST and then also our sample history, be asking your patient based on their pain of where that burn is, or correlate your OPQRST to the respiratory system if they are complaining of difficulty breathing. So this is an example of emergency care protocol for the burn emergency. We're going to arrive on scene. We're going to take our PPE precautions. We're going to determine that that scene is safe. First, we're going to remove that patient from the source of the burn, provide spinal immobilization if needed, if suspected, establish airway breathing circulation, suction as needed, provide ventilations, 10 to 12 breaths per minute, 12 to 20 for pediatrics and our infants, administer oxygenation if needed, if that SpO2 is less than 94%, determine the body surface area using the rule of nines or the rule of palms, cool that burn, and then apply sterile dressing and bandages for a burn sheet. Burn is less than 10%. You can go ahead and use the wet protocol. Maintain that body temperature, treat for shock, and then make sure that you get that patient in the appropriate facility. There we can see when we have a dry chemical burn, remove the affected clothing, brush off that chemical, and then irrigate with large amounts of water. Liquid chemical burn, remove affected clothing, large amounts of water. Burns in the hands and feet, remove rings, jewelry, make sure that you are separating the digits. Chemical burns, heavy amounts of water. So as you can see, even though our burn injuries are substantial, our treatment plan is relatively basic. Remove that individual, remove the clothing, cool that burn, rapid transport. So our case study conclusion, Bill cools the patient's burns with sterile water as Ariana completes a primary assessment, places the patient on oxygen to maintain her SpO2 above 94%. She then completes a rapid secondary assessment. The patient is alert, complaining of pain, has some hoarseness and continuation of that cough, scattered rhonchi and wheezes in the lungs, but difficult to discern whether they're related to COPD or from that injury. The EMTs are concerned with the possibility of airway burns, so they begin transport without further delay. Medical direction advises transport to the closest burn center about 35 miles away with the request for ALS intercept. En route, they dress the burns with dry, sterile dressings, continue to assess the airway, and repeat every 5 minutes because that patient is critical. So lesson summary: burns, they can be dramatic, be associated with other life-threatening complications and injuries. That's why it's so important that we are doing a good head-to-toe trauma assessment of our patients. Focus on life threats first, just like any other patients. Identify immediate life threats within your general impression. Heavy aggressive treatment on our airway, breathing, and circulation. Inhalation burns, substantial injury that we need to be treating with aggressive airway treatments. Manage airway breathing, manage oxygenation, make sure that you're transporting to a critical burn center at this time. That does it for burns. So make sure that you dive into some of those specific tables and dive into the picture demographics of the body surface area calculations with the rule of palms and the rule of nines. Thanks, everybody.